Medurstand. Understanding Medicine.
This is Professor Aziz-ur-Rehman from Medurstand-Understanding Medicine. Earlier I covered various types of anemias, and now we are going to start with various types of leukemias. Today's video will be basically an introduction, and following videos will cover various types of leukemias in more detail. So in introduction, what is leukemia? It is a cancer. You all know any growth of the tissue which is uncontrolled, which is more than required, is called cancer. And if this kind of growth arises from the bone marrow, and that would be called a leukemia. And it is characterized by marked leukocytosis, generally speaking. And leukocytosis, obviously you all know, mean increase in the number of white cell count. Because these leukemias can affect all cell series, and usually there is increased count. And another reason to have increased count is infection. So whenever there is increased count, our first I think impression is to see if this is leukemia or simple infection. But not only there is marked leukocytosis, there is presence of abnormal cells, premature cells in the blood. So immature cells in the peripheral blood would actually indicate the presence of leukemia. Depending upon which type of leukemia you are dealing with, is it acute or chronic, there could be massive leukocytosis like in hundreds and thousands, or it may be just minimal, and in some cases there may not be leukocytosis. In some acute leukemias there may be in fact reduction in cells. So that is little tricky, but generally speaking you should expect marked leukocytosis with presence of immature cell in peripheral blood. Now you all know these days CBC is done by the machine, and most newer automatic machines, they can pick up the presence of abnormal cells, and they would indicate that this smear needs to be examined manually. But typically we ask our hematologist colleagues to comment on the peripheral smear, and they will tell us if any abnormal cells are present or not. And of course there are many types of abnormal cells. Most important one is the blast cells, so that will tell us if the leukemia is present or not. Then abnormal bone marrow. Obviously the actual pathology is in the bone marrow, so bone marrow will show various types of abnormalities, and that we will discuss when we discuss bone marrow aspiration biopsy as a diagnosis. So this is the introduction. It arises from stem cells and can be of any cell type. You know, stem cells, in the bone marrow there is a cell which is the father of all other cells. It proliferates and differentiates into different types of cells. We have red cells coming from the bone marrow, we have platelets coming from the bone marrow, we have various types of white cells coming from the bone marrow. They all differentiate from the stem cell. So this leukemia actually arises from the stem cell or from any cell which is actually now differentiated to become a specific type of white cells or red cell or platelet. Classification can be of various types. I think first is the biological behavior. How aggressive is the cancer? How aggressive is leukemia? Is it acute or chronic? Now acute, you know, is something which comes relatively suddenly and usually is more serious. And it could be from a myeloid series or it could be from lymphoid series. Now these are two series. After stem cells, I will show you, after stem cells, these cells, they differentiate into myeloid and the lymphoid. So leukemia could be acute, and acute leukemia could belong to myeloid series or lymphoid series. Or leukemia can be chronic, and chronic is something which comes slowly, and it's not just a time, actually their biological behavior is different. This is very violent and can't wait and has to show itself suddenly. And this one is relatively slow but less likely to be treatable, and as we will discuss later. And again, chronic leukemia can be of myeloid series or lymphoid series. This is the general concept. Now we have more technical classification, as I will be showing you shortly. Now, biological behavior of leukemia. Let's examine in some more detail acute leukemias. They are generally speaking short history. There is short history. Patient may be well only maybe days or weeks ago, and suddenly and apparently a febrile illness developed, and patient thought it is some infection, and but later on when the tests were done, it showed that it was actually leukemia. And patient may present with pallor, fatigue, and fever. I think fever is the commonest manifestation of acute leukemia. It may be due to acute leukemia itself, or it could be because of the superimposed infection. Right? So it is usually hard to tell what is exactly the cause of fever in a particular patient, but most these patients, they undergo investigation to find out if there is any infection, and they are usually treated with antibiotics initially. Fatigue means they have this purpuric spots. This is because of bone marrow, because the platelets are reduced. Pallor means there is anemia. Patient may look pale. Now, why pallor? Because if there is leukemia arising from, say, myeloid or lymphoid cells, it is going to expand. Once it expands, it is going to take up the normal bone marrow space. Like brain, we have limited space in the bone marrow because bone marrow is bounded by the bone itself. It can't expand. So we have to accommodate everybody in that space. Once the malignant tissue, the leukemic cells expand, they expand at the expense of other normal healthy cells. So that is why if somebody has leukemia arising from, say, white cells, myeloid cells, it is going to take up the bone marrow, and then red blood cells population will be reduced, resulting in pallor, and platelet population will also be reduced, resulting in thrombocytopenia and purpura. And fever, because white cells are also either less in number or non-functional, and these patients are prone to infection. So these are three typical presenting features of acute leukemia. It has got aggressive behavior. That means if not treated, it is going to be fatal very shortly. I think with few exceptions, if not diagnosed or treated, acute leukemia would be fatal almost universally. If not diagnosed and treated. There may be some exceptions, but that is generally considered to be the natural course of acute leukemia. More likely to be curable. Now this is very interesting. Although it is more likely to be fatal if not diagnosed or treated, but at the same time it is more likely to be curable if diagnosed and treated. Okay, so details will be discussed later. This is about acute leukemia. Now let's take chronic leukemias. In chronic leukemias, there is long history. Patient may be unwell, may be giving history of fever for the last several months. There may be history of weight loss. There may be history of general weakness and pallor for many months. And symptoms may be minimal, and sometimes it may be an incidental finding. Do you know what is incidental finding? That means patient was undergoing for some investigation for some other reason. Like for example, patient was to undergo a cataract surgery or some other surgery, and blood test was done, and we got surprised that the total count is 150,000, full of lymphocytes, and we make a diagnosis of chronic lymphocytic leukemia, although patients didn't have much symptoms. So this could be the presentation of chronic leukemia. And the course is indolent course. That means it would not be very aggressive, would not kill the person within weeks, but it would linger on for several months, maybe years, even without treatment, and then ultimately it will also be fatal. Less likely to be curable. Now, very luckily, we have now curable treatment in chronic leukemias also. I think maybe 10 years ago, there was no treatment. 10, 15 years ago, this is just an approximate 15 years ago, we just try to, we would try to keep the count in a decent range so that there is no plugging of the vessels. We would not be able to cure leukemia, but we will just try to keep the cell count low by using different chemotherapies. But these days, after better understanding of the leukemias and better understanding the mutation which causes the leukemia, it is definitely possible to cure even chronic leukemias with specifically targeted chemotherapies. Etiology of leukemia, generally not known. That means it is usually not possible to pinpoint our finger on one cause in one individual. But generally speaking, they are genetic factors. You know, genetic factors are very important in leukemias also. Mutations. I think this is currently the most widely accepted etiology. Somebody just undergoes a mutation, point mutation. Why? Because of some viral infection, exposure to radiation, exposure to some other things. We don't know, but in many leukemias, like many other cancers, a point mutation has been identified that has actually not only explained why leukemia occurs, but that has also provided an opportunity to correct this mutation and to cure leukemias. Pathogenesis, this is just an arbitrary 4 steps through which a disease process develops. First, there is genetic mutation, and this mutation may be inherited or may be acquired in that individual due to something. So that is the first point, mutation. And then there is this mutation usually causes abnormal growth of cells and abnormal apoptosis. You know, normally all our cells, skin cells, sperm cells, hair cells, mucosal cells, blood cells, they are under a regulatory control. There is a very, very complex system which ensures that only a certain number of cells are present at that time, at one time, as many as we need. But that mechanism, that cross-check mechanism is affected, and there is ruthless and unchecked growth of cells. So that is one thing. Apoptosis means there is programmed death. This is also a normal phenomenon. Every cell in the body, like white cells, red blood cells, other cells, liver cells, skin cells, every cell after a certain time, which is different for different cells, must die in a normal physiological way. It's not necrosis, it's apoptosis, and that is also impaired. So more cells are being produced and less cells are being taken away. So that means there is increased cell count. This would of course lead to marked leukocytosis. Leukocytosis means the increased number of cells in the peripheral smear. Normally it is 4 to 11, right? You know that it's normal, but it could go to 20, 30, 40, 50, 60, or even 150, 350, 400, it could go to that. So if it goes to that level, it is likely to block the blood vessels and cause various ischemic damages in the eye, in the kidneys, in the digits, everywhere. And tissue infiltration, and this tissue infiltration would cause damage. If there is infiltration of spleen, there would be splenomegaly. Infiltration into the lymph node would cause lymphadenopathy. Infiltration into the brain would cause ischemia, brain damage. Into eyes would cause eye damage. And this infiltration into the tissue, it could sometimes present like tumors on the skin, or tumor in the orbit, or tumor in the mediastinum. So these are different manifestations. So that is basically the pathogenesis. Diagnosis of leukemia. Number one, I think we need to keep a high index of suspicion. Pallor, fever are common conditions. We often see people with anemia because of simple iron deficiency. And we also see people with fever because of mostly viral infection, some bacterial infection. But purpura is less common. Purpura indicates the presence of thrombocytopenia. If there is pallor, fever along with purpura, I think should be a very high index of suspicion that you are not dealing with something ordinary. It is likely to be something serious, possibly leukemia. Then lymphadenopathy, especially leukemias of lymphoid series. In lymphoma also, but in leukemias of lymphoid series, there would be significant lymphadenopathy. Sometimes lymphadenopathy may be the first point of diagnosis. Sometimes patient is not symptomatic. We just examine and we find lymph nodes, and when we do blood tests and other tests, we find out that patient actually had leukemia. Splenomegaly, spleen may also be enlarged in some leukemias. In some it is massively enlarged, like in chronic myeloid leukemia. Splenomegaly may be massive. It may be so big that it fills the whole abdomen. It could come to the mid of abdomen, or even right, like foci, could be that big. Or similarly, in some other condition, there could be massive splenomegaly. In some, it is just minimal splenomegaly. In some acute leukemia, there may not be any splenomegaly, but this is one of the features. Hepatomegaly also, because the liver also is actually reticular endothelial system cells. There is infiltration of leukemic cells into the liver, and there may be hypertrophy, and there could be soft tissue tumors. Now, one or more of these features present in one individual would indicate the presence of leukemia. Of course, there may be other causes of all these signs. Like lymphadenopathy may be caused by infections, splenomegaly may be caused by cirrhosis, hepatomegaly may be caused by liver abscess, purpura may be caused by Hinox-Schönlein. So all these symptoms and signs, they have their own differential diagnosis, but when they present collectively, there should be very high index of suspicion of leukemia. And peripheral smear, very, very good test. Not just CBC, peripheral smear is a diagnostic test. I think after this, you would go simple CBC plus peripheral smear. So peripheral smear is very good. CBC mostly gives you the count. So that, of course, is very important. And the new CBC machines, they also give you, at least they will point out toward the possibility of abnormal cells, blast cells. And a peripheral smear examination by a hematologist, staining the peripheral smear with special stains, and then looking at that smear is very, very useful. Then bone marrow aspiration biopsy. Because the actual problem is in the bone marrow, these concepts are actually applicable to all type of leukemias. We will be discussing them individually also, but the concepts I am discussing today, they would be applicable to all types of leukemias. The bone marrow aspiration means we take a sample of bone marrow and then examine it under the microscope. Now, this is actually a very, very evolved science now. It's not just the simple inspection of the type of cells. There is special staining, immunophenotyping, and other things which are done by a trained hematologist, and then we can tell which particular type of leukemia we are dealing with. And there are two types of biopsies. One is simple aspiration. With aspiration, we suck some blood from the bone marrow. Previously, we used to do it from the sternum, but nowadays I think it's almost standard to take it from the hip bone, the iliac bone. In children, it may still be taken from the sternum or the long bone, but in adults, it is usually the iliac bone. And there are two types of biopsies. One is aspiration. We suck some blood. There are some details which I'm not going to talk about, but we suck some blood and that is examined just like we examined peripheral smear. But then there is a trifine biopsy also. In trifine biopsy, we take a cylinder of bone and the bone marrow along with the cells. So that definitely gives you a better diagnosis. Although the trifine biopsy is slightly more painful because the needle size is bigger. We actually take out a piece of bone, but of course it is very, very useful. It gives you a better information. Sometimes we decide which test to have, or sometimes first we do aspiration, and then if needed we go for trifine biopsy. Now this is a relatively new test, flow cytometry, and a very promising test. Now with this you could actually identify these abnormal cells from the peripheral blood also. So I think still the standard of diagnosis is bone marrow aspiration, at least in our country. But I guess once this is fully developed, then we will not have to go for bone marrow aspiration or trifine to diagnose leukemias. A final diagnosis would be possible from the peripheral examination, because all those leukemic cells, they circulate through the blood, and by using specific probes and techniques, and a specific type of premature cell may be identified in the peripheral blood, which gives us the correct diagnosis. Now, classification of leukemias, FAB classification. The first classification, acute versus chronic, was based on biological behavior, but this one is actually based on cell type, and FAB is French, American, British classification, and these were the scientists coming from different countries. They developed consensus and they came up with this classification, and it is still evolving. We get updates on this, but this is one which is currently available. The cell of origin is hematopoietic stem cell. Hematopoietic stem cell, any stem cell which has got the bone marrow origin, and it has got two types, myeloblast or lymphoblast. These are two broad categories. All further cells, they develop from this, and I think this is one classification. And then further on, myeloblast may be from M1 to M7. We used to call them by various names, and those names are still used, like myelocytic, promyelocytic, like that, monocytic. But I think technically they are referred to as M1, M2, M3, M4, M5, M6 and M7 on this series, and L1, L2, L3 in this series. So you may be confronted with somebody who has acute leukemia L3, like that, okay? So this is the classification. L for lymphocyte, L for lymphoblast, M for myeloblast. So this is one classification, but there's another classification. This is based on specific cell type and some unique antigen present on those cells, right? But there's another way of classifying also, which is more or less clinically oriented and more traditional, and based on what type of cell we see in the peripheral blood. Hematopoietic stem cell, myeloid, same thing. And if there is a tumor which arises from the myeloid, it would be called myeloproliferative disorder. This usually refers to chronic leukemias, okay? MPD is myeloproliferative disorder. Now this is actually leukemia, but some of these leukemias may have very, very benign course, and one might say that they are not actually leukemia. So that is why the word disorder is used. Myeloproliferative disorder is one category, and in this category we have CML, which is chronic myeloid leukemia. We have PV, which is polycythemia vera or polycythemia rubra vera. We used to call it polycythemia rubra vera, but now they call it polycythemia vera to differentiate it from secondary polycythemia. Many smokers, many patients with COPD also develop polycythemia, but that is secondary. So if there is no reason to have polycythemia, but patient has increased RBC mass, that would be called polycythemia vera. It's a type of chronic myeloproliferative disorder. Then there may be a condition where the platelets are in excess. This is called essential thrombocytosis, where platelet count is increased in number. In this RBCs, they look quite normal. In this platelets, morphologically, they look quite normal, only the number is increased. So this is called essential thrombocytosis. In these two conditions, many times we just adopt a wait and see policy. We don't intervene with medication because we know that the natural course of these two conditions is not that bad. Sometimes we do just what we call phlebotomies. We just take out some blood, but we don't give them chemotherapy. And last one is myelofibrosis. Myelofibrosis being fibrous component of the bone marrow start proliferating. So this is also part of myeloproliferative disorder. Now, interestingly, at the time of diagnosis, you have a picture of chronic myeloid leukemia, but by their inherent natural course, later on they may convert into another one, this way or that way, and sometimes more complex picture develops. And ultimately, most these things, they would result in myelofibrosis, which means the entire bone marrow is replaced by fibrous tissue. All these conditions are chronic and require long-term medication, treatment, and attention. So this is one series. The other one is lymphoproliferative disorder, you'd call them. And this is like CLL, chronic lymphocytic leukemia, and the other is non-Hodgkin lymphoma or Hodgkin lymphoma. Now, lymphoid series, we actually discussing leukemias, but basically lymphomas also arise from lymphoid cells. So if it arises from the bone marrow and takes the shape of chronic lymphocytic leukemia, then it will be diagnosed from the peripheral smear. But sometimes it may arise from the peripheral lymph node. And and not only lymph node, all body organs have lymphocytes in them. So it could actually arise from any tissue, but mostly from the lymph node, spleen, liver, intestine. But it could actually arise from anything. And it is Hodgkin. Hodgkin was the scientist who described it for this time. And then non-Hodgkin lymphoma or Hodgkin lymphoma. This will also be taken up in separate lectures. So this is basically classification of chronic hematologic disorder. The slide I presented just before this was mostly acute conditions. So that was it. I hope you liked this video, and this was basically an introduction to leukemias. And I think 3 or 4 more lectures would be coming, covering different type of leukemias. But as this science has evolved tremendously, I would still be talking about basics, because these conditions are nowadays not treated by the internists themselves. They are actually treated by oncologists in their specialized centers. So I would only be touching upon the part which I know and you need to know. And of course, these patients are to be referred to specialized center. With that, I'd like to thank you, and thank you for joining Medurstand, my channel, and I really look forward to see you in my next video. Thank you.